Wow, well, thank you. Tremendous comments from all three of you. I really appreciate that. I think I'll hold my comments back a bit and just open the floor now to questions. And I'd like to ask you a favor. As you ask your question, feel free to say something that you learned today, and especially what you hope might be achieved in the next phase of work of the IOM on this topic. So please, floor is open. Mark?
Yeah, hi, Mark Murray. I wanted to make a comment about Bob's last comment about measurement and using measures, and I wasn't sure what you were saying exactly in terms of your recommendation, but using measures that, that come up with, we achieve this result 90% of the time. You know, those kind of measures. And I think there's a difference between a goal and an expected outcome. That kind of informs this. But, you know, I was thinking of Peter's work. You know, when Peter does work with safety, he never says our goal is, you know, if you put a measure 90%, he never says that, you know, we want 90%. I just don't want to be the 10%, you know. So the way I look at the measurement that we ought to do, our goal is 100%. I mean, safety is 100%, access is 100%, delays are 100%. That's what we want. That's our goal. Now, the expected outcome, we may not achieve that. There may be a persistent defect inside the system, so we may not have achieved that yet, but our goal is always towards 100%. And I'm not sure if that's what you were saying when you said expand the measures towards the 90% example.
Right. So what I think the point I'd like to make is an integration of two concepts, the time dependency of variables and the way we take a measure. So let's just take a waiting time in the clinic. We may not care, and the patient might not really care if they wait 8 minutes. And it may not be that relevant. It may be very relevant if they wait 20 minutes or 30 minutes or 60 minutes. So there's a time dependency of the prioritization of that variable. It changes over time. And so means may not be a very good representation. It may be that the anger and the intolerance factor hits a certain threshold level, and that's what we have to optimize against. And so that's a different way of looking at a measure rather than just a mean measure. Now, this is not the quality measure where you want to achieve 100%, but we're not looking to get waiting times to 0. Most people won't care if they wait 1 minute versus 0 or 90 seconds versus 30 seconds. So there's, just like on the wards, if somebody has an elevated hypertension and they call you, it's kind of high but not too high. You're not going to stop coding the patient you're doing to go do that. But so there are interruption criteria about what becomes a prioritization. But too often, as I watch these models, they have too simplistic of approach of the kind of variable. So I'm just saying, as we advance the field, we should think more creatively about measures.
Thank you. Bill?
I'd like to make a comment on these two comments. There are, in engineering and systems engineering, there's a lot of variation, stochastic variation. It's random. And with random events happening, if you want to be something to be holding 100% of the time, your investment has to be so huge that you can't afford it. So you have to be satisfied sometimes, whether it's a 6 sigma or a 2 sigma or something, that you will meet that 2 sigma 95% of the time or 99% of the time. If you try to meet it 100% of the time, you just can't. I mean, the cost goes through the roof. And so we have to have these kinds of measures as well as the measures where we have less of the randomization that's occurring, where we can do things 100% of the time. So that's why you need the right measurement to meet the right problem that you're looking at. And that's all my only comment.
Thanks, Bill. I can't see whose hand is in the back, but please speak up.
Hi, I'm Sarah McComb from Purdue University, and I had 2 things that I'd like to just put out there for further consideration as far as scheduling is concerned. The first one is we've talked a lot about patients who call to try to get on the schedule. We have a very large cohort in this country of patients who need routine care for their disease management who don't pick up the phone call, who don't pick up the phone to call. They, like a diabetic patient. And so I think we also, as we're talking about scheduling, we need to think about what are we going to put in place to be proactive to get those people getting the care they need to avoid the more expensive care down the road. The other thing I wanted to mention is we talked about no-shows earlier today. I actually have been working with some colleagues we have a large data set about appointment behaviors, and we have a paper under review right now that's talking about we split people who cancel their appointment into two groups. One group canceled and they rescheduled immediately on that phone call. The other group canceled it but didn't reschedule. And when we looked at their adverse outcomes, ED visits and hospitalizations, the patients who cancel and do not immediately reschedule are statistically similar to the patients who no-show. So when you're thinking about how you're scheduling your patients, don't forget the ones who cancel when you're talking about how to make sure people are that people are coming to their appointments to get the care they need. And the population was the diabetic population. Again, that was a group of people who actually need to be seeing their physicians regularly or their care providers regularly.
Yeah, you want to comment, Christine?
I do. I'd like to respond to that because I'm a general internist in private practice, been in practice for 27 years until this week. And we have a no-show rate of 4%. But I think a lot of the reason our no-show rate is so low is that we have text reminders, phone reminders, letter reminders, and we also pre-schedule the patient 3, 6, 12 months down the line, and then we pre-schedule their lab. So if they don't show up for their lab, we have a chance to call them and get to them. We really do everything we can to make that visit as rich and meaningful as we can. And we reach out to them in that very proactive way. It still misses some of the people who are not on our radar screen, but I think for the people who are, there are a lot of detailed things we can do to keep them connected.
I'm going to make a provocative comment here. I've flipped my thinking on this a little bit, and maybe everyone wants to yell at me, but I think when a patient doesn't take a medicine we prescribed or doesn't show up for a visit that we scheduled, it's because they're smarter than we are. And that I think a learning system that actually was co-designed would take what we call noncompliance as information about overproduction.
Mind if I respond to that? Because just recently, I got the notion from someone else about shared decision-making around scheduling an appointment. I'm all for shared decision-making. I do it all over my work life. I had never thought about it around scheduling. As I start to do it, I learn from patients what they want. It feels right to me, but they may choose a much different interval than I was planning on, to your point.
Patty?
Two comments. One about this not showing up. When we did a study of the 130,000 users of our community health centers, and in our first cut, 79,000 of them were healthy and well, and probably didn't need to be seen for anything except preventive care. The kids needed their immunizations and stuff like that. Yet they were in our mix along with the 1,200 patients who were train wrecks, who also had the same visit. It's sort of like what you were talking about and what was said at the beginning. We have a one-trick pony. So if we're going to talk about access, I do think we have to be more granular about what patients need what, and they have to be part of that discussion. The other comment I was going to make about access, which isn't relevant to the VA because they're all insured if they're using the VA, but we haven't talked about the reality that if you're among the millions of Americans who are not insured, forget access in the same way that you're talking about if you're insured. And if we have this whole discussion about access for the country, not just for the VA, and we don't put that reality into a mix, that if you call up for an appointment and you say, I don't have insurance, good luck. So I think we have to be careful not to eliminate that completely from our discussion.
Thank you. Chris Lehman, Vanderbilt University. Two quick comments. Number one, I wanted to get back to the example of the concierge service. I'm a little bit worried about it. You know, the question was, could you get access to your doctor today, the stats of the different countries? I think if we were to ask this question associated with income level, we would see some of the biggest discrepancies in this country. And I worry with this example of the concierge service that there was a promotion to create a two-tier access system, which I don't think you meant to. So one of the things that I would encourage is looking into the possibility of developing these type of access models for underserved populations as well as other people. And the other comment I had is, I don't want to yell at Dr. Berwick. I think your statement was a little bit of a hyperbole. There are obviously lots of reasons why people cancel. Pressure outside, let's say the possibility to attend an IOM meeting might trump the desire to go and have your blood pressure checked because you're fairly asymptomatic from that. So I think there might be some truth to that statement, but it's not generalizable, I think.
Thanks. I just want to clarify. Corolla's care was not provided under a concierge service. It was provided under an alternative quality contract, an experimental kind of an ACO. If you look at the data on the patients in Corolla's cohort, more than 50% of them will tell you that their health is excellent or very good, and yet they're brought into physician office visits about 7 times a year, 7 to 9 times a year, and then they end up hospitalized. So this is under an experimental contract that says we'll give you a fee for a year and for this patient, and take a look at, just like an ACO alternative, take a look at where are the costs over that year. And they designed the care to keep Corolla out of the hospital. The most impactful intervention that I saw the physician provide to Corolla was he not only assessed her mental state and her psychological state, looked at her weight and did all of the typical physical things. But the intervention that I thought had the greatest impact was he watched her walk with her walker across the room, and then she sat in a chair that was lower than this. So she kind of dumped down into the chair. And he said, I predict a hip fracture within the next several months. 1, because you're going to fall getting into the chair, or 2, you're going to fall getting out. And so her son came and put a little platform under her chair, and she now gets in and out of the chair like that. But it wasn't concierge. It's thinking about the payment as driving, looking at care for a year as opposed to. So there are very poor patients in the same experiment.
Patricia McGafkin.
This actually plays into a little bit about what we're just talking about right now, and that is, what are the alternate care models of the future, and how do we deploy, for example, our veterans who are medics who come back, and how do we infuse them into perhaps needing to go out and reach those people who won't pick up the phone and try to make up appointments, or to deal with the Corollas. So I absolutely, believe that those are going to be questions we have to, and opportunities we have to dig into. And Dawn, this plays into the question you asked about what do we need to be thinking about the future in terms of this whole issue. And I think there are a lot of things, but let me just name 2. One, and this has been a nagging thought the entire day I've been sitting here, is our workforce and what's happening to the workforce overall in terms of our primary care physicians, the aging of the workforce and the supply of people who can provide care over time. Also was thinking about that, Maureen, in light of the slides that you showed from the Commonwealth Fund that looks at, what can we learn from other countries who have supplies of workforces that are smaller than we have here. And I realize payment models and other things play into this. But that was one element. And then there's another element that kind of came to mind when you talked about the exam rooms without beds in them. And it struck me that one of the things that I'd really like to see us think about down the road is how do we not only engage more in those types of discussions, but how do we bring family members and others who are not co-located into that virtual conversation? And then another element and final element is, how do we bring the multi-specialists that are caring for the patients together into those discussions? When I think about the time and the waste involved with phone calls back and forth, visits back and forth, specialists not talking to primary care physicians, specialists not talking to one another, those are the kinds of things that I think are going to be really important in how we re-engineer healthcare in the future. And you're probably thinking about this for the report overall, and we don't know what those answers are, but I'd really like people to think not about just what do we have to do now, but how are we taking all these futuristic needs and issues into consideration.
Thank you so much, Patricia. So in the back?
Terry Pipe from ASU. So again, thinking a bit futuristically and thinking about the wearable devices now that capture health indicators like physical activity, sleep, blood pressure, that even a phone with a GPS. In the future, how can we capture this data that exists pre-encounter and unlinked to the EHR in terms of predicting and not only health need and demand, but also helping predict and model what will be needed from the supply side of the equation. So any thoughts about that?
Can I?
Oh, yes, please.
I was just going to say, yesterday at the Commonwealth Fund meeting, one of the leaders from Patients Like Me was there, and she is very interested in having the data that patients are collecting individually through their devices and as a cohort entered into electronic records. She's finding a lot of barriers, but she said, if you knew what we knew, you would think in a very different way about how to construct care. So I think you're exactly right.
I wanted to respond to Patricia's comment about how do we get more out of our subspecialists as well as our primary care specialists, and how do we make those links stronger. And my vision would be that we would have, healthcare is a social enterprise, and we would have social connections between our primary care specialists and our other specialists. And I'm thinking about the ECHO project, which others here probably know more about than I, but a way of bringing in that expertise to the primary care physician, who can then take care of a wider band of the patient's needs, which I think is better for the patient to get more of their care from the same person. And then it's better for their longevity in the career because they have a larger competency, and it comes by this tight connection with supportive subspecialists with a completely, of course, different payment model.
So, Mike Davies from the VA, as sort of one voice who's been in the midst of this storm from the beginning. In the middle of the operations part of this storm, there's a couple comments I would make. There's a great amount of talent in the room, and I'm, overwhelmed by the great ideas and stuff. And this is probably the early adopters and innovators in the country, I'm guessing. How much of the rest of the country is caught or could be caught or is now in a situation like the VA has been in recently? And what can we do to think about sort of the good of the whole? So from my perspective, you have an organization that has some of, if not the best technical quality, using averages, compared to the private sector. VA's technical quality is fantastic. Looking at patient satisfaction, the patient satisfaction scores in the VA have been fantastic for 10 years running, actually. Yet, we're in a situation where right under our noses, we have a 30-year-old scheduling system that wasn't working very well. That wasn't fixed, in my view, anyway. And we couldn't measure supply. We couldn't manage supply. We had waiting times that were opaque, certainly in retrospect, at least to some extent, that led to a lot of scheduler turnover, which led to, patients not having somebody to call, which led to nurses having to schedule, doctors having to schedule. They didn't schedule correctly. So you had a whole bunch more errors made, and then ultimately, it sort of tumbles into a very complex system that's trying to be patched together and, comes at a head with this crisis. So, in the context of all of this forward-thinking, clearly, exciting and relevant comments, I would just ask to think about the question of how do we assure some floor, some standards, something that's a little deeper, that would have given us some predictive value that this was going to happen, and maybe some attention to and warning signs to this at a maybe at a big system level, but certainly at a hospital level, and what other systems are maybe in this situation now. So I would just wonder, sort of back to Peter's comments, is there some sort of assurance that we need to take as a country that there is a certain minimal level of standards here? And I think that's one thing that I've taken away from today. As we're going and doing the innovative stuff, we need to have a floor.
Comments on that? Let me reflect back what Mike just said. This sounds really important, as many of the comments do, but if I hear you, Mike, the guidance the IOM might want to offer the nation is there's a piece about the basics that almost anyone could use and adopt that in the opinion of the people thinking about this would really help get things straight. And then there's another piece about very comprehensive redesign that would build into healthcare something that isn't there now at a new level. That I don't know if that's helpful to you, Gary and Mike. Peter, you want to comment on that?
I think that's right, Don. I think that there is probably a known enough to put a stake in the ground. I might also add to that, to build on Bob's point, that right now it also seems, though we know some, there's a void of what I might call the basic science of improvement. And it's too applied for NSF, and it's too basic for ARC, and there's this gap about, it's really, and you know this better than I do, it's hard to find where you can go to mature these basic questions or to build capacity, because we need, virtually every health system should have some of the people in these rooms, and they don't exist. It's hard to get funding for training programs for them, and so I think that may be a research and capacity layer to add to that, perhaps.
So what did I learn? Like Mike, I think I learned there are a lot of bright ideas and a lot of bright people in the room. And I think my frustration is I've also learned I'm still concerned about scale and pace and capacity building and mechanisms to do that. And I think that might be another piece of our recommendations. This is going far too slowly, and even if we figure out what this is, which will involve some testing, I don't see that there's a mechanism to deploy en masse across the country and a mechanism to build the capacity with the right skill sets to do that work. Now I have a question, because you referred to some of the pivotal moments in sort of healthcare recently. And the patient safety movement strikes me as fundamentally successful. And I think a key ingredient of that, as Maureen referred to, was will. And it resonated with everybody, 98,000 lives. This is completely unacceptable from a care, from a patient, from a cost perspective. We have a challenge. So how do we create that same passion about access outside of this room? Because without that, I see this really going slowly.
I can't help editorializing. I don't think the patient safety movement has yet been successful, and I think it's exactly around the issues of pace and deployment that you're talking about and the basic capacities that Mike's question's about. We sort of know what to do now, but if you biopsy the average hospital today, despite the goodwill, the awareness, they've all read the reports, they're just not there. I think Peter's nailed a big piece of this in his recent work, because they're still thinking project by project, and it's not going to get where we need to be. So I would take heart at how much we've done, but also know how much we have left to do.
But when we cite the statistic, everybody thinks it's unacceptable, 98,000 lives.
That's progress.
But when
yes.
we cite the statistic,
About,
X% can't get an appointment in Y days, a lot of people just, that's the way it's been, that's the way it's always going to be. And that's a fundamental change in thinking we're going to have to accomplish if we're going to then do all of the systems work.
Absolutely. Gary, and then
Just very brief comment, because I'll have a platform in a few minutes. But it seems to me that this is in part very much the charge of our committee, that we really are about establishing, informed by today's work, as well as many other things we've studied and are doing, but we are charged with recommending standards for access and scheduling for the country as a whole. We don't want to do that, though, in a vacuum. We don't want to recommend unattainable standards, although we may comment on the ideal and where we'd like to see the system go. And I think none of us have wanted to spend our time on this work feeling like it's not going to get anywhere. So I'm intent on publishing this report, but then what's the next steps? And what's the derivative work? And whether it's IOM's work, whether it's IHI's work, whether it's everybody's work, we need to create a movement. And I think that the trump card is really the patients. And how do we galvanize our communities around what is reasonable to expect from the healthcare system, and then how do we ensure that we use the systems engineering approaches as well as the many other things we've talked about to make that happen.
So I want to follow up on some of the comments earlier about the reason why Mayo is so successful, because they have 100 system engineers, or when Peter mentioned about there is a gap that there's no training involved. So I think one of the, as Amanda is leading the effort, is the IOM study on really systems training for healthcare professionals. And I think that might be really a great opportunity, because if you put an engineer in the healthcare setting, they still will have to be trained so that they understand the system, and then they can build models that are realistic and be able to be used. In the same way, I think training healthcare professionals and understanding the system dependencies and how to make use of some of the sophisticated techniques and really march forward to do the health transformation is equally important. And I think that's one of the study that IOM is also leading, and that kind of tie back to what all the comments are, because I think it's really interesting. Mayo really have the luxury of 100 system engineers there to be able to look at all the changes that they would like to do and be able to make it a success. But I see some of the hospitals that really want to do it, but they keep coming back to us and say, well, we don't have the resource. We can't even hire these people because we can't even get those, finance people to agree to pay for the personnel. So I think that is really a key shortage that we have to address.
Good afternoon. Amy Cohn, University of Michigan, and to expand on this, I think to Jim's point, one of the challenges perhaps in some of the scheduling, and I have certainly seen in my own work that scheduling is not seen as sexy, that the notion of scheduling is something that's going to have major impact. In this room, I think we all see it. There are a lot of people out there who shrug their shoulders and say, you're scheduling, that's clinical work. I think we all recognize that it's not trivial work, but we don't have a good mechanism not only for training the people who are going to be doing the scheduling, but for training the people who are going to develop the fundamental science that we're all talking about to change the way that we schedule. And I think at its core, this comes back to multidisciplinary training, where we're bringing engineering students, going back to not just postdoc and PhD, but undergraduate level engineering students, working with clinical students, working in clinical environments, and finding mechanisms to finance that. Again, this notion that funding for this, is it basic science or is it consulting work? But ultimately, if we are not training people to be able to do this work, then 5 and 10 and 15 years from now, they will be having these conversations with the same frustration.
I just want to say a couple things and make a comment. Two things. One is back to the issue of scheduling is not all that sexy. The issue really is, again, this is all about adult learning. We're all, like, to make change, people have to see what's in it for them. And so I think however you position this has to be what's the end game? What's the end point? What's in it for patients and clinicians? And oh, by the way, the mechanism to getting there is this particular way. I think that's really crucial. The other part is, and I think Peter and David participated, and I hope you'll take this in the right way. This is an extraordinary group of people. I'm privileged to be here. You are amazingly good at identifying the challenges, the problems, the needs, all the things that you need to get it absolutely perfect and absolutely right. You're brilliant at it. But I would encourage the IOM and in the process of your doing this report to get really clear about some things people could do immediately that would make a difference in the scheduling, like thinking prospectively about what's the patient's need, thinking about what the clinicians need in, and I bet there will be micro-level changes that would make day-to-day lives for people easier right away. So please take the view to what people can do in an immediate sense, just in changing their frame and their perspective and some basic simple things they could do that then builds the behavior change and the will for the later activities. It's just my plea to you all.
Comment?
To comment on a few of these last ideas, you could consult with Dave or Farah about the Cincinnati Children's, but they're using, as an example, something you could do today, advanced nurses who understand what the flow of a particular patient is. So if you took your highest volume operative procedure, when you call Cincinnati Children's to book a surgical procedure, you're not booking OR time. You're booking everything from what tests you're going to need, pre-op scheduling, medications, IV solutions, because that's all predictable and knowable. And if we were just today, these nurses love their jobs. They sit in a little room and design how to link all the pieces of care. Therefore, the ICU isn't surprised when you've got 4 trach revisions on a Thursday morning, because they've designed the entire process of care. And those are nurses who are doing engineering work, I think, to produce much better flow through the system. They, in effect, have opened up another operating room for every specialty because the flow is so well managed now that with the same physical capacity and the same staffing, they're able to do more procedures.
So I agree with you. We need to also get very immediate, and so 2 immediate things that I would suggest be considered that I haven't heard talked about. One would be scheduling on a wave. So a lot of people schedule on a very rigid 15-minute or 30-minute block, and you have a no-show, you have a patient who's late, you have a patient who takes longer, or you have a patient who doesn't take long. And you can never reuse that unused time if you're only scheduling on these rigid 15-minute intervals. And you can never, despite your best prediction, predict exactly how long someone will take. But if you schedule on a wave, you've got a little bit of fluidity in every half hour of time. So that's one thing. And I think the other thing we can continue to learn from Theta Care, the value of pre-visit planning in making the work go more smoothly. And I picked this up from Theta Care, that at the end of each visit, you plan the next. So they say the next appointment starts today. You already start pre-planning the next appointment at the end of this appointment, and that's part of giving that wraparound care for patients.
Hi, Ashley Benedict, Visinate. So one of the things I was thinking of, like an immediate thing or looking into the future, I'm working with somebody from the Midwest Mountain VERC, so there's 4 VERCs within the VA, and this guy did simulation models of a call center. And he ran a ton of combinations of call centers. And so I have, every facility has a call center. We don't have a centralized call center. Some VISNs might. And they don't know how to staff it. They staff maybe to the average. So then we all know there's variability in calls. Somebody was saying earlier, you try to call from 9 to 11, you're hoping you get through. Maybe there's not going to be anybody answering the phone at noon. And so he ran all these simulations and scenarios, and he's creating a tool that I can go in and I can plug in, on average, how many people are calling, or how many phone calls do we receive, how long is the call center open, and it will tell me, okay, what's your normal abandonment rate? You know, how long will someone wait on the phone before they hang up? And what is your process time from receiving the call to ending the call? And you plug those in, and then it tells you, like, well, what are you trying to achieve in terms of how many people are going to abandon, and what are you trying to achieve in terms of answering the phone within 30 seconds. And it will give you kind of an optimized or a suggestion on how many agents you should have answering the phone. It took them some time and it's complex, but I think of these scheduling algorithms that you said, you know, you went to Informs 25 years ago and you saw the same sort of scheduling algorithms that were out there. Like, can we not generalize it where somebody could go in and plug in their numbers or plug in Zelda's example of, you know, trying to optimize when people should be slated. Could we not create some kind of robust simulations that people could go and play with, you know, just kind of manipulate? I think of the bullwhip effect with the beer game, if anybody's played that, but trying to understand bullwhip, and you go in and you say, you know, downstream, what am I going to need? So getting people to understand who might not be industrial engineers, but getting them to understand some of these concepts or playing around with simulations and different models.
Yeah, Bob.
So having started in healthcare as industrial engineering, there's a trump card that you're not mentioning that physicians have played forever in their interactions with industrial engineers, and it's, well, I don't want to schedule that way. And they don't. And they have control. And so it's mostly the individual groups of docs say, this is the way I want to do it, and I don't care what your scheduler says, we're not going to do it that way. And they've owned a lot of power, and they've pushed a lot of the engineers out of healthcare because they can't ever win. And the doctor will always say, well, that will hurt patient care, and the engineer doesn't know enough to be able to counter that argument, and so they win. And that's permeated this for a long time, including as we speak right now. I mean, so it's a cultural thing.
I just want to make a kind of summary comment, not necessarily shut things down. We have a few more minutes. I'm hearing two voices in the room. I think they're both good and both valuable. And I want to clarify what I think I'm hearing and have you push back. So a number of you are saying, look, these problems in scheduling are important, they're focused, they've been around a long time. There must be some things we can tell people that they could just get to work doing that would really change the game. You're not talking about comprehensive transformation. You're talking about scheduling mechanics, and that's not at all a derogatory term, that would really help if we could deploy them quickly and people would adopt them. And I believe that. So I think, Michael, you started that direction of this conversation. And so there's a plea for simplicity and clarity and deployability. Great. The second voice is quite different, and it's actually reminding me of the work the IOM did that led to Crossing the Quality Chasm and eventually the New Learning Organization reports. If you go back to the Chasm report, 2001, I was on that committee, so I'm intimately familiar with it. That was very comprehensive. It was an attempt to envision a new way to design and give care that would lead to much higher quality against the defects we knew. So there was a constellation of aims: safe, effective, patient-centered, timely, efficient, equitable care. There was a new set of microsystem designs, 10 simple rules for design of the healthcare microsystem. There were certain classes of suggested changes for the organizational leadership patterns that would support those microsystems. And there was a constellation of recommendations around the environment, payment, and training, and things like that. So there were 4 tiers of recommendations there, very comprehensive: aims, microsystem design, organizational design, and environmental design. Now that I think back, that was 14 years ago. We didn't go where this group is going. That is, think of all the new knowledge here about every one of those levels, including completely different microsystems. I don't think the Chasm report mentions telemedicine. It mentions non-visit care, but didn't push the envelope far on that at all. It really didn't get into workforce design issues. It did talk about patient empowerment, but not co-design, not the level that Maureen was just talking about. And so part of me is being very ambitious here and saying there is an opportunity here, I think, to re-envision the production of healthcare, nothing less than that, probably at all 4 levels. What should it accomplish? Not just safe, effective, patient-centered, timely, efficient, equitable care, but the triple aim and maybe beyond. Not just microsystem design, but a whole new set of principles for how delivery goes, which may do away with visits. And not just the organization that we classically understand, but there's new organizational frameworks being contemplated here and really a different payment system. I ran Medicare, and I'll tell you, just trying to understand how we would pay for a telemedicine visit, don't go there. I mean, so there has to be some guidance on that. So I think two levels of both important ambitions, but I'll put that on the table. Maybe time for two more questions, Gary, and then we'll you give the benediction. Bill, and yes.
I would posit, just like in the Toyota system, by the way, I would posit that the work being done by this committee on how to improve scheduling will just open the box. It will really open the box to system issues, flow issues, staffing issues, workload issues, every issue that comes up in the hospital, the choice of exams or tests and so on to give patients. The scheduling part will start to open that up, and you'll start raising other questions because the scheduling won't work. It won't work.
Why is it such a powerful window or big window on the whole system, Bill?
I think it's a powerful window on the system when you start to measure it and see what is happening and why the schedules are a problem. If you start to measure the different things and why schedules may or may not be able to improve them, you start getting at the other fundamental problems that are inside the flow and the structure of the organization. And it's a nice way to get in, I think, through the scheduling part, because everybody understands there's problems in scheduling. But if you go to somebody and say, well, there's too many lab tests, or there's not enough capacity here or there, they may or may not listen. And they may or may not want to change behavior. But when you start to say, well, the schedule is pointing out that we've got a problem here. I think Gene Litvak has showed that Eugene has done this in the operating room. Basically, he's shown the fact that you have artificial variation and random variation, and that you have to manage that by changing physician behavior. And you have to change the physician behavior. I mean, I've heard Fred Reichman talk about that. That pointed that out. Now, it's not the scheduling of the operating rooms, but it leads to how the other kinds of changes you have to make the schedules work. I think it's a powerful tool to get in and make change.
Thank you. One last question, then we'll get...
Rick Dart from Denver Health. First, I wanted to echo what was just said, because one of the first things that happened when Patty asked us to start an appointment center is we got it going, and then I could go back to her and say, we can now very efficiently tell a patient that there are no available appointments. So, and we can do that with 100% accuracy. So it exposed access issues that were much more painful than the appointment center issues. The last thing I wanted to mention, though, I brought this up a little bit earlier, but one thing you can do right now, I feel, is, and I get the feeling that it gets discredited a lot because it's a triage function, but there wasn't much talk about the relationship between an appointment center and nurse triage, because I happen to run both of those. There's incredible synergies there, and it's something you can do like that. You can transfer a patient and makes them very happy for you to say to them, are you sick right now? Yes. Okay, would you like to talk to a nurse? Oh, yes, that would be great. And when you can take care of a third of those right off the bat, it not only decreases the volume, but it makes patients very happy. And what really strikes me about it is many of the things that my primary training is emergency medicine. One of the things that really strikes me about this is that many of the things I see in the ED, we're always taken care of by the family doc. Urinary tract infections is a great example, without ever seeing the patient. I don't know if people in here may realize that, but our younger colleagues don't get it. They think every patient has to be seen. So we do emergency contraception, we do UTIs, we do earaches, pink eye. The list is long of the things that you can handle that way, and free up the system, maybe make appointment visits longer so that the providers can handle those more complex cases. Thanks.
Any of the panelists want to make some final comments here at all? Well, thank you. I've really enjoyed this, and join me in thanking the panel.